There is a specific kind of medical purgatory that happens when a test result comes back and the doctor uses the word borderline. The patient has been feeling terrible. They finally get the blood draw. They wait for the call, and the answer is essentially that they are not sick enough to be treated, but not healthy enough to be dismissed. We are looking at a piece from My Adrenal Life today about partial adrenal insufficiency, that gray area.
The gray area is actually one of the most destabilizing places to live. When you get a definitive diagnosis, even a severe one, there is a protocol. There is a name for the thing happening in the bark. But when an endocrinologist looks at your cortisol response and says it is technically acceptable, you are left holding this massive discrepancy. The day-to-day reality of your body shutting down, having these sudden, unpredictable drops in energy, and a piece of paper that says you are fine. That creates a profound sense of self-doubt. You start wondering if you are somehow generating the symptoms yourself simply because the medical framework does not have a clean box to put you in.
That is a structural problem. The tools we use to measure disease are binary, but the body is analog. It degrades or struggles on a spectrum.
Exactly. Actually, wait, the better way to put it is that the testing we rely on, specifically the ACTH stimulation test, is engineered to catch catastrophic failure. It looks for the cliff edge. It is incredibly effective at identifying primary adrenal insufficiency, where the adrenal glands are physically damaged and cannot produce cortisol no matter how much they are stimulated. But the body does not always fail all at once. Sometimes the dysfunction is upstream in the signaling, or the glands are just beginning to fatigue. So you get a test result that registers as normal because the adrenals managed to mount a response to a massive synthetic dose of hormone in a controlled lab setting. That does not mean they are functioning adequately across an entire Tuesday when you were dealing with a stressful commute, fighting off a cold, and trying to focus at work. The test proves the machine can turn on. It does not prove the machine can run. The machine can turn on, but it stalls in traffic. The clinical tools do not measure the stalling. They completely miss the stalling, and that is where the patient experience diverges so violently from the medical consensus. A person might wake up feeling relatively normal, have a moderate stressor around noon, and by 2 o'clock, they are experiencing profound weakness, dizziness, and nausea. They are not in a full adrenal crisis, which is what the emergency room looks for, but they are not functional either. The recovery from a standard exertion takes days instead of hours. Living with that inconsistency is exhausting. You cannot plan, you cannot trust your own capacity from one morning to the next, and because the labs look borderline, the medical advice is often just to rest, or worse, a referral to psychiatry, which introduces an entirely different kind of exhaustion, the effort of translating a physical reality to a doctor who is only looking at the paperwork. It becomes a second job. You are managing the illness, and you are managing the perception of the illness. The frustration of trying to articulate how your body responds to stress when the standard metric for that response says you're fine is isolating. We rely on the medical system to validate our physical reality. When it refuses to do so, because the function is evolving or borderline, the patient internalizes that failure. They think they're just not resilient enough. But the problem is biological. The HPA axis, the communication line between the hypothalamus, the pituitary, and the adrenal glands, is incredibly complex and sensitive. It does not just have an on and off switch.
Let us break that axis down. Hypothalamus, pituitary gland, adrenals. It is a communication chain.
It is a cascade. The hypothalamus senses stress, any kind of stress, physical, emotional, metabolic, and sends a signal to the pituitary gland. The pituitary then releases ACTH, which is the messenger that travels to the adrenal glands and tells them to produce cortisol. Cortisol is not just the stress hormone. It regulates blood pressure, blood glucose, metabolism, and inflammation. It is keeping the baseline operations running. In a healthy system, this communication happens constantly, adjusting minute by minute. If you stand up too fast, if you get a fright, if your blood sugar drops, the axis responds. But in secondary or tertiary adrenal insufficiency, the adrenal glands themselves are fine, at least initially. The problem is the signaling. The pituitary is not sending enough ACTH, or the hypothalamus is not signaling the pituitary. So the adrenals are sitting there waiting for instructions that never arrive.
They are perfectly capable of working, but they are being starved of the signal. And here is where the testing gets complicated. If you suspect adrenal insufficiency and you give that patient an ACTH stimulation test, you are bypassing the hypothalamus and the pituitary. You are injecting synthetic ACTH directly into the system. Since the adrenal glands have not been damaged, they receive that massive synthetic signal and they produce cortisol. The test looks normal. The doctor says your adrenals are fine, but the doctor did not test the whole chain. They only tested the last link. Over time, if the adrenals are consistently starved of ACTH, they will atrophy. But in the early stages, or in cases of partial insufficiency, they will still respond to the synthetic injection.
I don't know, that feels too clean to me. If the signaling is broken, wouldn't a baseline morning cortisol catch that? Why rely on the stimulation test if we know it bypasses the problem?
You would think the morning baseline would catch it, but sometimes it does. Morning cortisol is highly variable. The cutoff for a clearly abnormal morning cortisol is very low, often under 3 micrograms per deciliter. If your morning cortisol is a 5 or a 6, it is technically borderline. The endocrine guidelines often suggest that if the baseline is indeterminate, you move to the stimulation test. So the patient with a broken signaling chain gets a borderline baseline, proceeds to the stimulation test, passes the stimulation test because their adrenals haven't atrophied yet, and is told they do not have adrenal insufficiency. The very tool designed to provide clarity actually obscures the pathology because it is not measuring the right part of the system. That is a terrifying loop. The diagnostic algorithm actually protects the misdiagnosis. It really does. There are other tests, the insulin tolerance test, the metirapone test, that actually measure the entire HPA axis, but they are considered cumbersome, they have risks like inducing severe hypoglycemia, and they are rarely done outside of specialized endocrine centers. So the standard of care relies on the ACTH stimulation test. And to be fair to the test, it is highly sensitive for primary adrenal insufficiency, like Addison's disease, but a meta-analysis showed its sensitivity for secondary adrenal insufficiency is only about 64%. That means it misses more than a third of patients whose problem originates in the pituitary or hypothalamus. Those patients are living in the gray area. Their bodies are not responding to stress appropriately. They have the fatigue, the low blood pressure, the inability to recover, but they cannot get a diagnosis.
Let us trace the most common cause of that secondary failure: glucocorticoid use, steroids.
This is a massive issue. Millions of people take corticosteroids for asthma, autoimmune diseases, joint pain, skin conditions, prednisone, dexamethasone, even high-dose inhaled or topical steroids. When you introduce synthetic cortisol into the body, the hypothalamus and pituitary sense that there's plenty of hormones circulating, so they stop sending the signal. They downregulate. They essentially go to sleep. And if you take those medications for more than a few weeks, that sleep becomes quite deep. When you taper off the medication, the axis does not just wake up immediately. The pituitary has to remember how to secrete ACTH, and the adrenal glands, which may have started to atrophy from lack of use, have to rebuild their capacity. The system has been outsourced. Bringing it back in-house takes time.
It takes an agonizing amount of time. The recovery of the HPA axis after steroid use can take anywhere from 6 to 12 months, and in some cases, up to 2 to 4 years. And during that window, the patient is in a state of partial or evolving adrenal insufficiency. They are technically off the medication. Their doctor might consider them recovered from the original illness, but their stress response system is profoundly sluggish. They might have enough baseline cortisol to get out of bed, but the moment they face an infection, a stressful day at work, or even intense exercise, they crash. The axis simply cannot mount the necessary surge. And because the medical system does not have clear guidelines for monitoring this specific recovery phase, patients are often left to navigate these crashes alone, thinking their original disease is returning or that they are developing chronic fatigue.
Wait, does that actually hold? Because if the withdrawal is a known pharmacological effect, wouldn't tapering protocols account for that gap?
They account for preventing an immediate lethal adrenal crisis. Tapering is designed to step you down slowly enough that you don't end up in the emergency room. But tapering protocols do not guarantee that your axis returns to optimal function the moment the taper ends. That is the disconnect. The doctor finishes the taper and considers the job done because the crisis was averted. But the patient is left with an axis that is operating at 40% capacity. They're surviving, not thriving. The medical definition of a successful taper is simply the absence of a life-threatening event. The patient's definition of a successful taper is getting their life back. Those are two very different metrics. And that gap is where the emotional weight of this condition really takes root.
The emotional weight of being technically safe but functionally compromised.
And being told that your functional compromise is psychological. That is the hardest part. When your labs look borderline or your steroid taper is finished and you are still experiencing profound weakness, dizziness, and cognitive fog, the clinical gaze shifts. If the endocrinologist cannot find a clear biochemical failure, they often suggest it is depression or anxiety. And there is a devastating irony there. Having a chronically malfunctioning stress response system actually does cause psychiatric symptoms. Chronic low or fluctuating cortisol affects neurotransmitter function. It directly impacts the brain pathways that regulate mood. So the patient is told their physical symptoms are caused by anxiety, when in reality, their anxiety is a biological symptom of their endocrine dysfunction.
The symptom is weaponized to dismiss the disease.
It is a profoundly damaging experience. Research shows that patients who have chronic or rare diseases that go undiagnosed experience significantly higher rates of anxiety and depression precisely because of this medical gaslighting. One study found that 82% of rare disease patients report anxiety largely because they are misdiagnosed or made to believe their symptoms are psychosomatic. When an authority figure in a white coat tells you that the pain and exhaustion you feel are manifestations of your mind, it shatters your trust in your own body. Another study focusing on autoimmune and chronic conditions found that over 70% of patients who are misdiagnosed with psychosomatic conditions reported that the experience still deeply upset them decades later. The trauma of being disbelieved is sometimes harder to heal from than the physical condition itself.
Exactly. And for someone living with partial adrenal insufficiency, the inconsistency of the condition makes it even harder to defend yourself against that reprimand. Because there are good days. There are days where the signaling connects, the cortisol is adequate, and the person feels capable. They go for a hike, they clean their house, they work a 10-hour shift. And the people around them, sometimes even their doctors, see that and think, see, you are perfectly fine when you want to be. But what they don't see is the 3 days of complete physical collapse that follows. The unpredictability of a struggling axis looks like flakiness or malingering from the outside. The person cannot promise they will be at the dinner party on Saturday because they do not know what their baseline will be. The social isolation that stems from that unpredictability is immense.
How does someone actually navigate that when the map provided by the medical system is blank?
You have to build your own map, and you have to start by validating your own terrain. The My Adrenal Life article makes a beautiful point about beginning with awareness rather than demanding immediate change. If the labs are not giving you a clear answer, you have to become the instrument of measurement. You start tracking the patterns. You notice that a stressful conversation depletes your energy faster than a 2-mile walk. You notice that a sudden drop in temperature makes you dizzy. You begin to map the unique stressors that your specific HPA axis struggles to handle. And instead of pushing through those drops in energy, which is what our culture demands, you learn to pace. You shift from a paradigm of endurance to a paradigm of flexibility. You stop labeling the need to rest as a personal failure.
Pacing requires a level of acceptance that feels dangerously close to surrender.
It feels like grief. And we have to acknowledge that. Accepting that your body has unpredictable limits, especially when those limits are not validated by a definitive diagnosis, is a grieving process. You are mourning the reliable version of yourself. But pacing is not surrender. It is actually highly strategic resource management. If you know your axis cannot mount a stress response on demand, you stop demanding it unnecessarily. You build margins into your day. You prepare mentally for the fact that a seemingly small exertion might require a disproportionate recovery. You start making decisions based on your actual lived physiology, rather than the physiology the lab report says you should have. It is an act of gentle empowerment, taking your own experience seriously, even when the external validation is missing.
That is the fundamental pivot. And it is incredibly hard to do in isolation. That is why finding communities, reading patient narratives, looking at resources like the Adrenal Insufficiency Coalition is vital. Hearing someone else describe the exact bizarre pattern of afternoon nausea and sudden muscle weakness that you experience makes the invisible visible. It anchors you. The medical system is built to identify clear dysfunction. It is not built to hold space for the evolving, borderline, or inconsistent states of illness. Over time, as testing evolves or as an individual's condition either resolves or becomes more defined, the medical context might catch up. But in the meantime, the patient has to live their life. They cannot pause their existence waiting for a test to turn definitively positive.
We ask people to wait for the pathology to mature before we offer them the dignity of an
Which is profoundly cruel. We tell them to come back when they are sicker. Until then, the burden of proof is entirely on the patient. But the reality of partial adrenal insufficiency, or any borderline endocrine state, is that the absence of a diagnostic label does not cancel out the validity of the suffering. The body is communicating a struggle. Whether that struggle fits neatly into the current diagnostic criteria of the ACTH stimulation test is a limitation of the tool, not a failure of the patient. Learning to trust that internal communication, adjusting to the unpredictability without shame, that is the work. It is complex, it is often lonely, but it is deeply necessary. The tools will eventually catch up to the terrain.
Until then, you map it yourself.
You map it yourself, and you refuse to let anyone tell you that the ground you are standing on is not real.
It changes the way we think about medical certainty entirely. Send this to someone who has been told their labs are perfectly fine while they know something is fundamentally wrong.